welcome to the Oral Apothecary Podcast, authentic chat about medicines, pharmacy and healthcare in the UK.
Pharmacists Jamie, Gimmo and STC take on topical and controversial stories, but keep it edgy yet light-hearted.
Podcasts share their career-defining drug, song and book, and also share their joyful patient stories.
Welcome to the Oral Apothecary Podcast. My name is Jamie Hayes. For this episode, we're looking at data, and we're joined by Brian McKenna. Brian is Director of Research and NHS Service Analytics at the Bennett Institute at the University of Oxford. We'll welcome Brian in a moment as he shares a drug for our formulary, his career anthem, and recommends a book for the Oral Apothecary Library. Our micro-discussion this week looks at the role of data in changing prescribing behaviour. You can't wait, I know. But first, let me welcome my two fellow apothecaries. STC is in Bournemouth and Gimmo is in Cardiff. Welcome both.
Evening.
Evening all.
So we saw each other on Thursday, Jamie, at the RPS Wales conference.
Very briefly.
Very briefly. It was really good. Shout out to alumni Chris Martin, who chaired it excellently and actually very kindly gave us a couple of shout outs. So that was very much appreciated, Chris. Thank you very much. And actually, it was Ellen Jones was the director for Wales for the Royal Pharmaceutical Society by the time this goes out, and so that was her last, I think, official duty, and I think she's been there a good few years, and so big shout out to Ellen and thank you for everything she's done. She'll be sorely missed, although she's going on to HEIW, which is the sort of pharmacy dean at HEIW in Wales, so she'll still be around. So well done, Alan.
But didn't she get us into do our first live oral apothecary at the RPS conference, if I remember rightly?
That's right.
Yeah. She would have been very instrumental. 11 years at RPS, I think. And so, congratulations, Ellen.
Well, here's the RPS thread then, because I was at RPS HQ in London this week with Claire Howard, Lawrence Brad and others. But it was a celebration of the polypharmacy programme Getting the Balance Right, which is the work that the Health Innovation Network, led by Claire Howard and Amy Semple, and very well attended, so much so that there were, guess how many, there were 11 oral apothecary alumni at the event. I managed to get a picture with all of them, bar two who then got in the pub afterwards, and so I put that up on LinkedIn. So that was a great day, talking about all the work that we've been doing around problematic polypharmacy. And while we're talking about health innovation networks, should also like to shout out Paula Bennett, who's the chief nurse at Greater Manchester Health Innovation Network, who contacted us, said she saw on LinkedIn the artificial intelligence episode, listened, was hooked, and has told me that she's now, as she's a regular commuter, so she started the back catalogue, which is always lovely to hear for us. So she says she doesn't want to get to the end, so that's lovely. And also we should shout out Alex Farmer, who's also contacted us this week following the last episode to tell us very useful information. This is public service broadcasting, that if you have got an NHS email account, you can now get the TalkSpace app on your phone and you can then access the TalkSpace, so that's very helpful. She did say beware, they contact you and say, oh, we see you be looking at this information with regard to research. So she did give a slight warning, but I won't go into detail. But thank you, Alex.
Very good. Okay, let's move on straight away and welcome our guest. It's a pleasure to welcome Brian McKenna to the Oral Apothecary. Brian works for NHS England as a pharmacist advisor and primary care medicines data clinical lead. Previously a clinical fellow and deputy head of medicines optimisation at Islington Clinical Commissioning Group. He's worked in a variety of hospitals in London and Australia. He's completed a master's in public health and he's currently doing a PhD. But more importantly than masters and PhDs, Brian has a specialist interest in pharmacomedy. Welcome to the podcast, Brian.
Hey lads, thank you very much for having me.
So we've got to start with pharmacomedy then, Brian. So just to let you get into your stride, okay, I asked ChatGPT today what was pharmacomedy. Okay, they said it's not a standard term you'll find in pharmacy medicine or comedy textbooks. It's usually used in one of two ways: comedy about pharmacy and medicines, a niche form of medical humour where comedians, often pharmacists, doctors or healthcare professionals, use jokes, sketches or stand-up routines based on the quirks of medicines, prescribing, patient interactions or healthcare systems. Or it's an educational tool. Some educators and science communicators use comedy to make pharmacology concepts more memorable and engaging for students, professionals, or the public. And so I'll just start you off, Brian. A proton walks into a pharmacy. The pharmacist asks, why so positive?
Go on.
Wind blows through.
Over to you, Brian.
If everybody listens to the end, I'll do it. Last 15 minutes, top to tail, pharma comedy. If you want one, I'll give you one. Where does morphine act in cows?
Where does morphine act in cows?
On the moo receptors.
Oh,
God, that's a deep joke.
That's niche. That's niche.
Just before we came on, you were about to give us a joke about propranolol, because you said, we talked a lot about propranolol in the last episode. Can you give that to us?
I did, so you did. So on a scale of 1 to 10, what is the funniest beta blocker? A 10-along.
Oh, I got it. You've got a career in cracker writing, Brian.
Yeah, that's right.
Right, can we get to the data, lads? Come on.
Don't give up your day job, I reckon. Anyway, Jamie's done stand-up. I keep saying I'm going to do stand-up, but I never have. Have you actually done stand-up, Brian, with pharma stuff? No. Okay, so only Jamie has done that so far of the four of us.
I didn't know that, Jamie, but that's a conversation for another time.
Yeah. So, Brian, thanks for coming on. Give us an idea of the things that you get involved with then. What's on the agenda at the moment at the Bennett Institute?
Yeah, so I work at the Bennett Institute at the University of Oxford. We're a bit of an unusual group, so we're based in a big academic institutions. There's a lot of researchers in a group at the moment. Traditional academic researchers. We've got whole teams of full-stack software engineers, and we've got a lot of people called clinical informaticians, pharmacists, doctors. And what we do is we build software tools on top of NHS data, build on some other types of data as well, but primarily on NHS data. And that's to do two things. One, to generate new evidence, and we do that through Open Safely. But we also do audit and feedback to doctors and nurses, mostly in primary care, but we've recently started in hospitals, and that's Open Prescribing. It's got 20,000 unique users every single month. And my day-to-day job is focused on keeping those tools running, contributing content, making sure they're safe, effective, and generating and doing research.
Prescribing data is reading the tea leaves almost, isn't it?
It is. Prescribing there, that's my first love, shall we say. So that's Open Prescribing. It's where I came across the Bennett Institute first. So I've been working as a prescribing advisor in Islington for many years, and like the prescribing advisors, the old people back in the old days who got them all the data in the packed data in the big folders, and then there was the National Prescribing Centre, and they got the data from the NHS Business Services Authority. I was doing that job, and it was great. We were going around printing off charts using Excel to do things, and then one day in about 2015, I was sent Open Prescribing for the first time, and I nearly fell off my chair. I was like, this is how we need to do audit and feedback with our GPs. It's going to change my job. So I sat down and composed an email to Ben Goldacre, who set up the Bennett Institute, and told him everything that was wrong with his tool. I said, you've gone wrong here, here, and here with Open Prescribing. So that email exchange went on to about a year, where I said all the things were wrong with Open Prescribing, and eventually they just said, will you just come and work with us and help us make it better? So that's how I started. Yeah. That's
a bold email to send as well, Brian.
It is. I sent it very nicely and very politely. But yeah, no, it was great. But I could really see the opportunity of how it changed how prescribing advisors go about their jobs. And we know today, that was in its first few weeks, but we now have a huge amount of users. We know ICBs use it all the time in their roles. We know 60% of general practices are signed up to Open Prescribing. And that's we do a lot of focus on how to improve prescribing through giving doctors, nurses, pharmacists data at the coalface that is useful for them. And importantly, how they connect. I think there's a lot of data in the NHS and just sent around, and why does it matter? You sit there. So on every measure on Open Prescribing, you'll see a very clear why it matters with very clear links to nice guidance and what you should do. So you're not sitting there scratching your chin. We do produce research where, we think about very knotty issues and try to work out solutions. But for our tools, busy doctor, busy pharmacist in a surgery, you've got, 30 seconds to look at a bit of data maybe. You might be on your lunch break in a clinical meeting. You have to eat your sandwiches. You have to ring your kids to school about something. You might have 2 minutes. So we want to really hammer home, get the message, prioritize what is most important for that doctor, that general practice. So they can sit and reflect on, what we do well. So we spend a lot of time in prescribing by surfacing what people do well. I think sometimes in data there's a audit and feedback temptation to get into what people do badly. But most people do, most things grand. They do some things very well, and then they do a few things they need to improve on, or maybe they haven't heard of the new NICE guidance that just came out last week or in the last few months because they've been focused on the leaky roof in the practice. So that's what we try to do with our data, make it actionable, why it matters, and then people can go away and act and do all the other important things, because data is one part of the day job and gives you useful context, but it's not the only thing that you need to deliver good clinical care.
And that's the thing about that's good about open prescribing, isn't it? And is that it's trying to make data a tool to improve quality as opposed to how it's often used, which is a tool to manage performance. So I was part of the original sort of group of people involved in the old Welsh prescribing indicators. I'm sure Jamie was as well back in the day. There's a group of us, and they were always designed as an aid memoir and a tool to go into GP practices in a much more holistic conversation about prescribing. And they quite rapidly become, they're still used for that, but I would say they're more often used as, you're a bad practice, you're a good practice, and you need to up this and down that. And I think we've got to get better at how we use data to help improve quality as opposed to just performance manage.
Yeah, data for improvement rather than data for judgment.
100%, and that's certainly more we go on what we're more focused on. So during the pandemic, we launched the Open Prescribing Improvement Radar, which is actually a set of algorithms deep beneath the surface that looks for changes in prescribing measures that suggest somebody has done a really good quality improvement program. So you can go onto Open Prescribing, for example, and look at the improvement rate if you're interested in your opioid prescribing, let's say. And we have a set of tools there that has identified in the last year practices or ICBs in England, so large administrative areas for those that aren't based in England, that have their prescribing has changed for the better, except that value judgment does not always apply. So that tool identifies that, brings up those areas, and then if you're interested in looking at it, then you can Google that area. Maybe someone in that area, you can ring them up and ask them what they did.
Oh wow.
And we found that has been really useful. And I've talked to some of the people who our tool has identified, and you ring them up and you hear really great stories about how they did things, usually a heroic leader. And that could be the practice partner, or it could be the student that's in there for 3 weeks and does an audit on optimizing statin doses. So yeah, I'm much more interested in those types of things, and we do a lot of that on open prescribing these days.
So, Brian, how many times do you think the word data appears in the NHS 10-year plan?
I have read the NHS 10-year plan quite a
lot.
Well,
I'll save you time. If you listen to the first episode of this series where we say, well, I do anyway, I just say, look, it's a bunch of words on a page, until you give us a roadmap as to what we're actually going to do. But anyway, the answer is 178. But the point is that, it, as you would imagine, a bit like it talks about genomics and AI, it lauds the fact that, the NHS has unparalleled data. It talks about the NHS number, the powerful tool for data linkage. And as healthcare becomes more data driven, the NHS has a huge advantage. So, and your boss, Ben Goldacre, we were looking at the paper that he wrote with many others about bringing NHS data analysis into the 21st century in the Royal Society of Medicine. And he talks about, doesn't he, that clinicians and commissioners often lack the skills and support needed to ask good questions of data. So I'm assuming you agree with that, but is that one of the benchmarks as to how you think about providing it? So I'm a customer, I use open prescribing, I use it for certain things. Obviously, I can't use it for other things because you don't have the NHS data, patient NHS number. But is that one of the planks? And it is very user-friendly. When I look at it, it's very user-friendly. And you've got all the deciles in there, haven't you? So you can see where you are. You've got the trend. You've got the national median.
Yeah, so that's exactly what we do. Try to make it easy in a consultation room, in the lunchroom. I work for Mains as prescribing advisor. Our teams continue to work in general practice as part of the week and in our room. So we know how it is, how much under pressure. We know you are being pressured to learn about, maybe not you individually, but generally, better consultation skills, do coaching. There's so many things that people want you to learn. There's only a certain amount of things we can do for our CPD every year. So what we're really trying to do is, in our tools, break it down, not to its most simplest level, but provide you with the why it matters, the context, and prioritization. What's the most important thing for your practice? So you'll see that, you may not even see it on open prescribing, but if you look in your practice, you will see the measures arranged, the 100 or so measures arranged where you are the furthest from the English median. In every practice that is different. Some people think the dashboards are the same for everyone. You're actually seeing different information. So that's what we do in open prescribing. But related to 10-year plan, during the pandemic, we built a platform called Open Safely. So open prescribing is openly available medicines data that is on the internet and anyone can go and get it from anywhere. But at the start of pandemic, we were a little bit worried, we were looking bit concerned that the NHS did not have the data and the shape it needed to respond to, the world ending, basically. So we set out to build what became Open Safely on top of GP data. So GP medical records, as you mentioned there, contain an identifier and people's most secret medical history and lots of other things as well. So you can't put that on the internet. Traditional methods before the pandemic of how to access this data for research is basically take a copy and send it somewhere else out of the GP. So you copy it out of GP, send it somewhere else. People use the phrase
Texas or somewhere like that.
Somewhere in England. There's, there are frameworks around it, but essentially it's sent around based on trust. People say it's pseudo-anonymized is the phrase that used to be used. Pseudo means sham. You cannot anonymize GP data because of all the rich contextual information. If you take me, for example, if somebody had a copy of those records that were sent around, even though my name's not on it, my date of birth would be transformed into an age and my address might be in, London or Oxford. Anyone listening probably knows already that you could infer my accent. I'm white Irish. I came to this country at the age of 18 and I've lived in London and Oxford. Those three things probably enough to identify me. So that was the old way of doing things, and that limits how far you can share information. Start pandemic, we built Open Safely, which is a new innovative software approach. It's used in other industries, but first time in healthcare, where we installed Open Safely and we built it inside EMIS and TPP. So software inside EMIS and TPP. People's full medical records never leaves EMIS and TPP.
Those are the two GP record, two GP rest systems. Yeah.
Yeah. So across England, EMIS and TPP software is called System 1. EMIS is called EMIS Web. So they make it for every GP. So we built it inside EMIS and TPP. And a researcher never gets access to people's full raw records. And what they do is they use the Open Safely framework. They write it. The Open Safely robot goes to EMIS and TPP, runs their analysis. So they write their analysis outside. Robot goes to Open Safely main, and then it goes out to EMIS and TPP, and it brings back the results. So what the researchers see at the results at the end of the day. We built that at the start of the pandemic. So that facilitated access to 58 million people's GP records in this country. And that's been linked to hospital admission data and ONS death data. So the really key important things that we needed for the pandemic. So we're able to do rapid research on that. And the reason bringing up relation to open prescribing, we have also started to do and implement audit and feedback on that and start to do service monitoring, for want of a better phrase, but to help the NHS understand what is happening in general practice to deliver better services.
Yeah. So, as I said, it's very easy to look at, but for us, I would use it to look at, as you said, where am I in our practice or our PCN? But if I'm going to use another data set, so I use the NHS EPAC data because I want the actual patient details of the people who are on more than 10 medicines so that I can invite them for review. And then there are lots of others as well, aren't there? You can get data from Prescrip. You can pay to get Eclipse Live, for example, which has a very nice looking dashboard, I would say, when I've seen it last, but it's not freely available. So this is freely available, isn't it? Open Prescribing.
So Open Prescribing freely available, and then Open Safely, our new tool, it's free, it's available. Researchers are using it now, and we've built interfaces. You can go on the internet and you can see regional variations. So what you're used to seeing for your practice for medicines and open prescribing, we now have reports where you can look at different regions and what's happening. But the strength of the GP data, it's not just the medicines data. We have everything that's in the record. So you can start to look at breakdowns by different ethnicities, comorbidities. So do people with mental health issues get prescribed statins, etc.? So that's the two tools that we deliver. One is Frontline, you're using every day right now, and the Open Safely service, it's a much different scale of data, complete GP information. They were developing research, lots and lots and lots of research, the most productive research tool of its kind. And there is more and more coming around support for services and the day-to-day things that need to be changed.
So, and I was having a little chat offline with Jonathan Underhill, the fifth apothecary, about this. No, the sixth apothecary. Sixth or fifth?
Fifth.
So again, going back in the day when prescribing data first started and how we were using it, and I was thinking, I think possibly the first drug we used it for, Jane, was statins, maybe? Because it was around the time of 4S studies, and that was when the NPC was starting to produce their material, and so what I was sort of wondering and chatting briefly with him about was could we argue that was the first time that prescribing data had an impact on optimizing the use of a medicine? Because you could argue that we got prescribing the statins optimized to a certain extent using data, and I wonder what stories have you got, or what's the sort of impact you've had in terms of some of those. Can you point at some changes in prescribing on a regional, national basis, or something else that you think you might have influenced with the data?
Just specifically on medicines day, the first mention, you think, I don't know what year the story you were telling is, I would not like to guess, but the first mention of prescribing data I can find, nationally compiled medicines data, is actually 1924 in England. So it predates the NHS.
Laudanum prescribing.
Yeah, so it was a long time. But what we found since 1988, it's been widely shared internally in the NHS. Since 2010, it's been openly available. In 2015, open prescribing was built, and we've lots and lots. You can go on our website and read about lots of stories. My first ever thing that I did when I went to the Bennett Institute and learned to write some lines of code was to look at methotrexate prescribing, so unsafe methotrexate prescribing. So methotrexate, very, very effective and useful drug, but it's got some nasty side effects. And one of the unusual things about methotrexate is, as you all know, it's dosed once a week. And there are only two tablet strengths, 2.5 milligrams and 10 milligrams. Unfortunately, over the years, there's been many mix-ups between the 10 and 2.5s. And if you 4 10s and you're meant to get 4 2.5s, it's quite a big difference in the dose. And unfortunately, there's been some fatalities and unsafe things. So when I came to the Bennett Institute, we were looking at our methotrexate measures, and there seemed to be some unusual patterns in what was happening with methotrexate 10 milligrams. So this is the one that the NHS says, we shouldn't be using. So my first job to benches was to learn to write a Jupyter notebook, learn to write lines of analytic code. And I made that, and we did nice maps of the country, and we worked out that actually it was clustered around certain regions. So most areas had gotten rid of their methotrexate 10 milligrams prescribing the unsafe version, but we looked and it was clustered in a few areas. We wrote that up. We published it in a fancy pants journal, but we went out and talked about it. But also, we made the measures on open prescribing. We handed these back to GPs and pharmacists around the country, meds op teams. So the information was going back. And since then, and we have the NHS England safety team did a report last year, and we have, particularly in South East London, have mentioned how that paper and those measures, they'd sort of forgotten about the unsafe. There's other priorities. The methotrexate unsafe thing has been around a lot of years. They'd forgotten about it. When they were reminded, and when they had the audit and feedback data, they implemented new programs, and they went and looked every few months. And we know that in few areas, they had the higher amounts of methotrexate prescribed, and they eliminated. So that was my first ever one. So that was quite an experience, and learning to code, then learning the power of not just doing a one-off paper sits on a shelf, and some nerds, like probably the four of us, will read it. But a living brain, working with our software engineers, developing the living, breathing tool that lives on the internet and sends emails once a month to people, and how that can really support, the local discussions about what's going on and is it a priority fix. So that was, one of the many stories from over the years.
Can I come in and make a point and an observation, really, Brian? So lots of people come to me for communication training, presentation skills training, and the pharmacists that come often have prescribing data, and they have stories to tell, actually, and they've often used data and before and after an intervention, and often they've improved the intervention, usually decrease in prescribing. But when they bring the data, they focus so much on the data that they lose sight of the stories.
They lose the audience, I think is what you're trying to say.
They absolutely do. And so there's something about building that, and you can see the emotion and the passion that Brian has on the call tonight for the data. I'm going to give you a quote from Rory Sutherland, the behavioural economist and vice chair of Ogilvy, who he says, "We're often guilty of looking at things through the wrong end of the telescope." Yeah, and so honestly, people come and they talk about this wonderful intervention and they show the prescribing data, but we lose sight of there's a patient usually at the end of it, and the emotion that should go alongside, especially in influencing. Yep, especially in influencing. It's not just about the data, is it? It's about that emotion, tell a story, help the audience with the narrative.
Yeah, absolutely. And many stories. I'm not saying the best ever, but yeah, I don't know who said it, but I've heard said many times is data is just people with the tears wiped off. And I remember one day that was quite bad for my life is on open prescribing. We have charts of all the medicines in the BNF that are prescribed, and you can see for the whole country, and it's 5 years bar charts. And an open prescribing, the data comes in 6 weeks in arrears. So when we got the data in July 2020, and we actually saw the midazolam chart, and basically midazolam very flat for many years, same level. And then for April and May 2020, midazolam, you can go look at the charts, they are through the roof. And as you will know, many listeners will know that are drugs that are used at the end of life. And when you see that, sometimes you just, it's that emotion in the patients. Now, we can't on every chart think about it, and there's funny stories that come up in some of the data. But yeah, it's trying to think about the stories I won't tell here to all your listeners, some of it's sacrosanct. But yeah, trying to focus on the patient's data is just what I would say an abstract representation of reality. Like, it's one part of it. There's lots of other data that's out there that's not captured by computers and prescriptions, and that's why you always need local clinicians, even patients, looking at the data to contextualize for what it means. You'll never see us in open prescribing saying in Oxford going that place in Blackpool is not a good prescriber, because we don't know what's going on there. Say their benzo prescribing is high. Just give you one example. Say their benzo prescribing is high. Maybe they've got problems in their area, but maybe the GP is a light touch, gives out benzos, but maybe that's the GP in the area, the town, that's volunteered to take all the challenging cases. We don't know that, and that's for local people to have those discussions of what's really happening in their area.
So I think the point is that data is just one part of the story. But the other thing about data, just to put the thumb screws on you a little bit, whenever we provide data, and this is, I believe, still always to be the case, as soon as somebody sees that their area or their practice or themselves looks like somebody at the wrong end of the graph, okay, on the left or on the right, for unwanted variation, the first thing people still do is they question the validity of the data. So what's your answer to that from an open prescribing point of view?
From an open prescribing point of view, all our code is openly available. Everyone can go and check if they have issues with it. So a common thing is, we need a single version of the truth, or they point at another thing and go, I got a slightly different answer over here. So that comes down to like single version of truth is one of the most dangerous concepts I have come across in the NHS in terms of data, because firstly, as you mentioned, then when you go and talk to people, they just point at other things. So
The locum.
what we need, yes,
The pharmacist.
I'd even say they point at other data sources and say, oh,
Yeah.
your number is 14.5, but they got 16.5. And I'd sort of say, you know what, lads, it shouldn't be over 10. Can we just have that discussion? Like, there's going to be different reasons. Because when people are building platforms, first off, they might not be using the same raw data. So they might be getting prescribed data versus dispensed data. This is why you don't have the same thing all the time. Also, people make different choices when they define their questions. So some people might include certain antibiotics in the definition of antibiotics, and some people might not include some other things in that definition. So it'll be different. So that's why in open prescribing you've got very clear explanations of what's there. So that's how we try to handle that discussion, or try to support the people who are having those discussions. And this is the thing that is go back to your earlier point about training and education. There is no training program for the medicines optimization community, let's start with them, who go and talk to people about their prescribing for pharmacists. There's no training out there to have the discussion that I just talked about. A lot of it's passed down through oral tradition. You know, the people who were you mentioned it earlier, some of the National Prescribing Centre, they got training back in the early 2000s. That is no more. Some of their documents on the internet, it's passed down through the oral traditions and people go around that way. But moving outside medicines, there is no even culture of using data to improve things like we've done in medicine, save billions over the years, improve quality. It's been key to really the success of meds up and prescribing in this country. But if you go and look at, let's say another big area, blood tests, there's no data on blood tests anywhere. And there's been a few pockets of people, you know, motivated, heroic leaders going out to say, do you know what, you're using too many of this blood test. Maybe you should do a bit more of that blood test. So bring it back. Well, I think these discussions are hard. And we need to support people to do them better. And, you know, we've talked about the tools I've built and my teams have built and the people I work with. But our next foray, and we've written about this on the internet, is the future of medicines optimization. I think we need in the NHS, like a true version of a learning health system, you know, structured education and training for people to talk about the data. So take the data from the nerds like us in Oxford and the few other places you've mentioned, but go out and talk to people and clinicians. How do we drive behaviour change? How do we get a set curriculum? Like, what is the textbook? What is the manual? If you speak to
we're all about behaviour change on here.
Yeah.
Go
why is that? You know, if you go and talk to a cardiothoracic surgeon, they'll have all done basically the same course. They'll all basically have done read the same manuscripts and read the same books and been taught by the same people, and it'll be accredited by a Royal College. Computers, cardiothoracic surgery's like been around for a while. Computers are basically new. So we're still learning, getting the data out there. So lots more to be done in that space.
And I couldn't agree more. And Steve, you just made the point I was making earlier about when prescribing data come out, we were all a bit afraid it'd used for performance, and what happens is what you described is the first thing people look at is I'm at the wrong end of the chart. When I think in quality improvement, when I'm talking about data, we teach and get people to use data a lot, but we always try and emphasize that it's not about whether you're going up or down or where you are, it's what story is the data telling you, and that's really what we try and get people to focus on is the story, and that's always got to be taken in the wider context of other facts. I got an example from, again, I keep going back in the day. One of the areas of prescribing data was showing us, so we've got high benzodiazepine prescribing here, we've got high antidepressant prescribing, we've got, you know, all this stuff going on. And then when you take a step back, the town that we were looking at was Aberfan, which was the town that the disaster was, and you think, well, no wonder their prescribing's out of sync with the rest of the country.
That's the cold disaster, isn't it? When the slag heap came down just for the non-Welsh people and killed how many children? Killed
a whole generation of children. So no wonder their prescribing was out of sync. But looking at that data on its own, you could say this is a bad practice because their antidepressant prescribing is high. But of course it wasn't. There was multiple factors there, and actually the intervention we need there isn't prescribing advisors, it's different. And so that, I think that's the message I take home from this episode is think about what story the data is telling you, not what the numbers look like and what the charts look like.
So I just want to finish really by quoting Ben Goldacre in his paper that we just mentioned, and we'll put it in the show notes. And he says this: good data analysis is contextual. It is not just about knowing how to ask and answer a question using data, but knowing what the important questions to answer are and why, and how to interpret the answer in the context, which is essentially what we've just said. And guess what, guys? As a clinician, it doesn't have to involve data. That's how I work as a clinician. It's about asking the right questions, listening to the answers, contextualizing the person, their own values and preferences. It's no different to use data than it is to talk to a patient about what to do next.
The Oral Apothecary is sponsored by Jamie Hayes Executive Coaching and OneLessPill.com.
Right, let's move on then. We'll come back to some of this, I'm sure, in the micro discussion. Brian, I'm absolutely loving your, what's the right word? Spunk, I think, that when we just came on the pre-call, you said, I haven't picked my song yet. So you're okay, because song comes second in the three choices. The first is a memory evoking drug. What would you like to offer the Oral Apothecary Formulary?
So sometimes these things aren't thought of as drugs, but I am going to go for the COVID-19 vaccine.
Okay. Are you going to go for the Oxford one?
No, just the tremendous delivery of vaccines for a thing that was, unseen for 100 years, massive global pandemic. And to get a vaccine ready in the time they got it, we were, everyone through all the lockdowns. When that vaccine, there was the whole teams working on that. When that first vaccine was delivered on the 8th of December 2020, like, what an achievement. And then the rollout across certainly the Western world after that. I know there's problems with wider rollouts, but the sheer scale, I've never seen anything like it in my career. The memory evoking stuff, like, as part of I mentioned Open Safely, we built this tool. Our first ever paper was still the largest, I think, factors associated with dying from COVID, and we did that in May 2020. And when the Green Book for the COVID-19 vaccine was released on the 27th of November 2020, that study was one of the things in this country, in England, that was used to prioritise who did and didn't get the vaccines.
That's the Department of Health immunisation book, isn't it? The Green Book.
Yeah, so the Green Book that everyone would have on their shelf in their consulting rooms in the old days. I know now it's.
I was going to say, not now. Yeah.
Not now. So it doesn't even actually have a chapter number. The COVID-19 vaccine. The old school vaccines still have chapter numbers, but that one does not.
Oh, just like the BNF, right? Leave the numbers alone. We like the numbers in the BNF chapter.
Yeah, and then the memories of around that time, it was dark, it was winter, the vaccine campaign was starting around, I'll just talk about England, everywhere else was doing the same sorts of things. And at Open Safely at the Bennett Institute, we had the analytic access for the full GP records. I actually, used the Open Safety framework. I was writing the study that we were doing to monitor the rollout. So on the 15th of December 2020, and you can go and look, we haven't talked much about Open Safety tonight, but all the code is openly available online, and you can go and see all the studies. You can see on the 15th of December 2020, I executed the first study of who was and wasn't getting the vaccine. And when that result came back, Dr. Helen Curtis was the first person to see it in the secure environment. We already could see that the vaccine campaign was going phenomenally well. Absolutely brilliant. We know, like, overall amazing, and the work in general practices, hospital, vaccine centres, like second to one, all the people in the infrastructure delivering it. But we could already see that certain groups were not getting the vaccine at the same rate as the general average population. So people with mental health and
inverse care law.
Yeah, people with learning disabilities and people from ethnic minorities. That was within a week on the 22nd of December. We emailed ministers and senior NHS people to say, look, this is what's happening. It's really great, but there are these problems. And then we started to produce weekly reports. They went on the internet every week and got lots of coverage. And then the phenomenal thing was lots of the gaps were closed. People responded. There was particularly the learning disabilities community. They responded. The vaccine rules were changed about who was and wasn't eligible. In ethnic minority communities, lots of groups self-established, Northwest London Hindu communities setting up stalls to get vaccines campaign. There was some support from central government for different schemes. In my own community, the Irish community in London, our vaccine rate was lower. We set up, or the Irish charities through their umbrella group set up, stalls and fairs. It's Vaccine Lacala, Vaccinate Together, to try and close those gaps. So, that vaccine, all sorts of stuff came from it, as well as personally working on it day in, day out, on monitoring the uptake. And then we went on to monitor the effectiveness. Did they or didn't they work? Unfortunately, we know they worked very, very well, despite what you might hear on some other podcasts.
Yeah.
I was going to say vaccines are a good example of where data is perhaps misused, isn't it? And I'm going to say correlation doesn't equal causation. I don't know if we want to go into that.
Oh, let's not go near vaccine disinformation. It's a new space and challenging thing to deliver. But COVID vaccine, what
other fantastic thing happened during COVID? The Oral Apothecary podcast
was born.
So we've come full circle. There we go. A drug has been picked that exists in the life cycle of the podcast. That's the first.
Very good. Okay. Well, that's a great story. And to be so close to what was a once in a lifetime situation, that is very impressive. So thank you for that. So COVID-19 vaccine, we'll put that in. Okay. So I hope you've made up your mind next, because the next thing is a career anthem for the Oral Apothecary Spotify playlist. And guess what? It really is on Spotify. And in fact, our previous guest, Lawrence, contacted us this week to say how much he enjoyed it. And he said, I've been listening to the Oral Apothecary Spotify playlist. It really is eclectic. So, Brian, here's your chance. What are you going to offer us and why?
I'm going to go with Dropkick Murphys and Smash Stuff Up. Ooh. And I actually haven't listened to it in a long time, but you said Memory Evoking. We've just been talking about COVID-19 vaccine, and the last big gig I saw was in Ali Pali in London just before the lockdown. Was Dropkick Murphys and Kneecap, Ali Pali, great night, and they played one of their new songs, and everyone always groans when a band plays their new songs. But they did a thing I've never seen any other band do. On the screen behind it, they essentially did karaoke. They put all the lyrics up and everyone sang along, and it was great. And then I think they were the first big band who did streaming, because lockdowns happened earlier everywhere else compared to England, and they did it, and I watched it, and we were building open safely. Things were terrible, and I just had that song on my repeat for a few weeks, and we were, things were terrible with vaccine, but we were building open safety, the future, having GP data available for the first time ever. And I don't know, the lyrics Smash Stuff Up. It felt like we were just breaking through some of the old models and old ways of doing things, and but I haven't listened to it in years. But I thought when I saw it, I think, oh sure, Memory Evoking, that's it. If you ask me next week, it might be a completely different song. But
So I've had to look that up. I've not heard of that at all. So Smash Stuff Up by the Dropkick Murphys. Are we going to assume that they're Irish?
They're not. They're from Boston.
No way.
So they'd be
Irish American.
Of Irish origin, yeah. No, very proud of their Irish origin. But Irish Boston, I'm pretty sure.
Okay. Well, it'll go straight into the Oral Apothecary Spotify playlist. I thought you were going to come up with Always Look on the Bright Side of Life. Life of Brian. Anyway.
I'll ask you later. All right.
There's the pharma comedy bit again, folks.
Right, and the third thing is a book recommendation for the Oral Apothecary Library, Brian.
So that one, I'm going to go with Empire of Pain by Patrick Redden Keefe. I don't know if any of you have heard of that, but it's a history of the Sackler family.
Yes, I thought I'd heard of this. Yeah. Boo, hiss, hiss.
It's the big, thick white one, isn't it?
It is a very thick.
I got that for the library and read a bit of it, and then it was on Netflix, so I watched that.
Go on, Brian, explain. But particularly to the listener who might not be health professional.
So first of all, I'd say check out some of Patrick Redden Keefe's other books. They're all fantastic. So Empire of Pain is about the Sackler family in America. And it's actually the dynasty. It's not just about the current Sackler family. It's about their whole history. Sackler family are most in the news for being significant or figureheads in the opioid crisis in America, and through their company, they made a lot of money off death and misery from pushing opioids and misinformation about opioids onto the American public. The book itself is fantastic, understanding their origins. Did you know they invented the term, that family invented the term broad spectrum antibiotics? We use that all the time about antibiotics. We think of it probably as quite a neutral and good term, but it was invented by the Sackler family.
Really?
Yeah, so they've had huge in antibiotics, in benzos, a lot of influence there. The early chapters are all about that. And then more recent focus on the opioid crisis, how it developed, what the Sacklers did with their money. They invested in art galleries. Maybe someone seen a protest about getting their name off art galleries, as the real scale of what's gone on in America has happened, and the amount of deaths and misery. And say there's been there's other books around it. Dope Sick is another one.
That's right.
I think the book was called that, but that's certainly on Disney. That's a dramatization of the crisis, slightly different. And, in both of them, it also mentions data in the first few minutes of Dope Sick. It mentions IMS data and the role data played and how they pushed opioids in America. But I was going to say, that's the thing that links with this episode, isn't it? Is death death and misery on an industrial scale, and it was driven by misrepresentation. And I mean, it was... Yeah,
let's not slander ourselves here. I mean, I'm happy to take on the BBC and Transport for London, but maybe not the Sackler family. But yes, sorry, I thought I know I interjected, but I thought you were still finishing.
Well, I was just saying it was about how data was shared with the family practitioners and how it was used to convince them that it was a safe and positive drug, wasn't it?
Yeah, I mean, I won't link, but the name, we've already mentioned the book Bad Pharma, but that was, I don't know when that was written in relation to this book, but yeah, I mean, it makes my blood boil when I watch whether it's Dope Sick or the other one called The Pharmacist, which was also about a pharmacist whose son got hooked on. And we've mentioned this before in episodes. I think it still runs even now into hundreds of thousands of people each year in America still die in relation to opioid overdoses. It's absolutely sick. So, okay, great pick. Empire of the Sun by Patrick Radden.
Empire of Pain.
Empire. I'm thinking about music. I've gone back to Empire of the Sun, an Australia link there with Brian. So I'll say that again. Yes, Empire of Pain by Patrick Radden Keefe.
Thanks, Brian. Our micro discussion next by colleagues of Brian, Helen Curtis et al. From the Data Lab, University of Oxford, and colleagues from the Behavioural Insights team in London, evaluating the impact of a very low-cost intervention to increase practices' engagement with data and change prescribing behaviour. The holy grail for those of us working in medicines optimisation over the last 20 or 30 years. Start us off, Brian. What would you like to share with us about the paper?
Best paper ever written, aren't they? Amazing colleagues I have. It's a bit of an odd. So this paper was done just before I joined the team. So it's been in my periphery. I've heard a lot about it. I've heard the grumbles about trying to get it published and the problems with academic journals and how slow they are. But it's written before I joined the team, so I don't know it in minute detail. But for anyone who hasn't read it, it's straightforward, trying to increase engagement with data. And how can we do it low cost? Because a lot of audit and feedback to clinicians is very, very, very expensive. It's a lot of highly paid people who go around and spend lots of time in meetings. Before the pandemic, I was driving a lot of miles to get 20 minutes with a GP.
That's what I used to do.
Yeah, so this is about evaluating how can you do it at low cost to increase people's engagement with data first off, and then evaluate if it does change. So practices were saying letters, faxes and emails with their open prescribing dashboard, basically. And amazingly, some practices got their fax and looked at the URL and brought it over to their computer and went on there and wrote quite a long URL in and went and looked at their data. It was a bit more fancy pants than that. There were different arms. The Behavioural Insights team, who look at how people respond to language, amongst other things. They did different types of letters, faxes and emails. But overall, it showed that what is essentially unsolicited feedback, writing to people and telling them about their prescribing habits. Like if you're sitting in a practice in Blackpool.
So people listening know what it was about. It essentially was you looked at, or Open Prescribing looked at the prescribing data in a specific area. This was broad spec. This was prescribing of antibiotics, and then sent, as you say, unsolicited feedback in the form of a fax or a letter to the GP practice telling them about it, and then watched to see if anything happened. So that's the essence of the paper, isn't it?
Like a behavioural nudge, which we've spoken about before, haven't we, on this podcast?
Yeah, and I really liked it because this is a QI project on a national scale, isn't it? It's using data to influence behaviour, and the scope for this in so many areas, and automation as well comes into it. Yeah, I think it was a really interesting paper and a great. It got me thinking about what could we look at in the open prescribing data and do something similar with it.
And we do lots with them. We're continuing to do more. We got a bit distracted with Open Save. Do you know what the hardest thing doing the study was? Finding the addresses of GPs to write to. It's amazing. There is no national list. Like even the NHS central head office has no national list of email addresses and faxes for all the GPs in the country.
I was going to bring that up. That's GDPR gone mad, essentially, isn't it? So, I mean, I know when I've worked with Prescript, and you're thinking, well, if I wanted to be able to send the information, and here's the rub for me, okay? So if you look at the data, if I'd been the editor, I'm an associate editor for another journal, I think I would have been a little bit harsher, because I think the conclusions, let's be honest, the truth is that there isn't any evidence that it actually made a significant nudge. If you're looking at statistical significance, okay, that's the first thing I would say. I like the fact that it is easy, in inverted commas. That's the point, isn't it? You're saying, we've got the data, why don't we just chuck it out there, okay? But here's the bit about who actually received the data. And that's the bit that, as far as I can see, you don't actually know who received the data. So if that had arrived at my inbox, okay, as the lead clinical pharmacist, versus what probably was the practice management email, what do you think might have happened to that data compared to if it came into my inbox? And that's the bit that you just don't know. And maybe that's why it didn't show a significant improvement, because you don't actually know. In the same way they said, oh, we tried to look for a signal for harm. And I wrote down, well, how on earth would you find a signal for harm? So there's a lot of unknowns in it for me, but I get that it's easy to send the data.
Let me add to it. So it's the chucking the data out I'll go back to as well. Is in these behavioural interventions, when we used to do them, they literally were chucking stuff out. We would craft a letter, and it would just be written by anybody, and it would be sent out on maybe on a Monday. And then next time we'll do it, we might send it out on a Friday. And so now I'm assuming and hoping that as the behavioural insights team were obviously heavily involved, those type of things now are, you're consistent, aren't you, in sending a letter to general practice on a Monday or a fax or an email is different to sending it to general practice on a Thursday or a Friday. And the content of the letter isn't any old letter. It's not something we knock up on a call now and think, oh, that'll do. It's a letter that employs behavioural techniques and behavioural, the behavioural change wheel sort of insights as well into what works to change practice. So it's low cost, definitely, but actually there's still a lot of work goes into providing a low cost, easy intervention, isn't it?
Oh yeah, it's not free, but yeah, it's lower cost than traditional methods. What I would say about it is unsolicited, and what we now have with Open Prescribing, mentioning your point about who gets the message, we know every practice in the country can sign up for their own tailored email alert, and that's essentially solicited. People sign up themselves and they get similar information to what's in there. So that's really good. And there's different ways, and I think what's really good about this is starting to test these things and writing them up and seeing what works and learning what doesn't. That's the really thing we need to do at healthcare. And particularly for audit and feedback, because people don't realize, like, audit and feedback has a small effect, really good small effect. So the latest Cochrane review, which is the reviews of the entire evidence base for lots of different things, go look at it if you have a spare 5 minutes. But they've done a review of audit and feedback, and they do it every few years. And the latest effect suggests that audit and feedback, go into the weeds of it, but basically gives a small effect of about 6.6% improvement. Now, that is small, but across the whole of a health service or across the whole world, that is huge. That's bigger effects than a lot of drugs. And what I'm interested in is how can we get that 6 or 10 or 15% really effectively all the time? Because new drugs are only going to give small for a few patients, relatively speaking. If we can get audit and feedback, a learning system held right, we can deliver huge change. And the 6% seems small. Some of our studies seem small, but I think with data as well, people have got used to hearing big numbers. So they hear things about data and AI and, we're going to save 282 million. We're going to save 1 billion, famous claim in the NHS. We've so effectively saved £1 billion. We are stopping this program, was a claim just before the pandemic from an NHS organisation. So those big numbers are generally produced with data. But actually, when you get into a paper like this and look at the meat and drink of it, audit and feedback is great. It can be effective, design different things. This study was effective for increasing data engagement. The actual impact on prescribing was not effective in that time frame. But I think audit and feedback as a whole, if we can get this right, that's going to be the route to better healthcare.
Yeah, but I think, and again, I think we're actually having a fierce agreement, okay? In other words, this particular paper, and as you say, that's the point about doing research, is you learn and then you tweak it and you work out, well, how do you get it to the right person? That's my point, is because actually I'm fully with it. I understand the Cochrane audit and feedback is the thing, right? 6% is a lot, like you say. But actually, as I say, if it came to me, or if I did, I've done this several times in different practices, I've taken all the data, I've worked out everybody's antibiotic prescribing per how many patients they see, and I've looked at the proportion of them that are the 3 C's antibiotics, okay? And I've plotted it as a funnel chart, and I've literally flopped it around and showed everybody, okay? And I gave them numbers, and then they said, no, let's, come on, we're all mature enough now, let's put names to it. And I'll tell you, all bar one of those people that were massively out on unwanted variation came to me privately and said, Steve, I need you to help me. Why is it that I look like I'm different to my colleagues? That's audit and feedback right there. And clearly that's taken a lot of my time versus unsolicited. So I'm not saying we shouldn't do this. I'm just saying that in this particular study, it didn't actually show a statistical significant improvement. But I'm not saying we should give up on it because, as you say, it's unsolicited, it's potentially cheap. If we can validate the data, I think the key bit to it is getting it to the right person to be able to do the behavioural change.
If you told a story as well, Steve, you would have had even more impact. Okay, thanks all. A big thank you to Brian for joining us on the Oral Apothecary and for sharing his stories, his desert island drug, his career anthem, and his book for the Oral Apothecary Library. Coming up next time, we're joined by Professor Alistair Boxall. Alistair is a professor in environmental science at the University of York. His research focuses on understanding emerging and future ecological and health risks posed by chemical contaminants in the natural environment. You can contact us via X at Oral Apothecary. You can follow us on LinkedIn, our preferred place to do business with you. Please do sign up and follow us. We'd love to hear from you. You can email us at theoralapothecarypod@gmail.com, and the website, don't forget, is theoralapothecary.com. Gimmo now with a final ingredient.
Okay, thanks Brian, that was fantastic. You took me down a bit of a memory lane as well, back to when I was early days as a GP pharmacist and looking at prescribing data. And I've been sitting here all for the hour trying to think of some medicines jokes, and I've failed completely. So perhaps that's one for the listeners. So send us in your favourite jokes, and we'll read them out in our Christmas special.
Oh, I've just thought of something. Shouldn't we say when this podcast goes out? But we have been invited to the Bennett Institute, and are going to be doing a live Oral Apothecary live show. Brian, do you just want to shout out what the name of the conference is and how people can come to it?
Yes, we are the Bennett Institute at the University of Oxford, and we are hosting our annual conference. And this year it's about medicines data, and we're looking for, it's not a traditional academic conference. Academics are welcome and some will be presenting their work, but we also want to hear from meds op teams around the country, people at the coalface who've done great things with data. We will have speakers who've built big data infrastructure, hospital medicines data, primary care stuff, some of the people that have been mentioned in this call. So it's at the Bennett Institute in December. If you go to Bennett, B-E 2 N's, E 2 T's, .ox.ac.uk, or you just Google Bennett Oxford Conference. I'm sure you'll find it, and I'm sure we can get something in the show notes or on the LinkedIn.
We will. It's on the 10th and 11th of December.
And we'll see you there. Yeah, thank you, Brian. So if we've got our maths right, and it was actually Brian who pointed this out, this episode goes out on Halloween. So happy Halloween, as the Americans would say. And for the final ingredient this week, I wanted to go a bit spooky. So picture this. You wake up to the smell of frying. In the kitchen, pans are scattered. Cutlery lies on the floor and on the table. A half-eaten dinner you have no memory of making. Or worse, you find scraps of paper covered in strange handwriting. Notes written on the wall in your own hand, but with no recollection of when or why you wrote them. What's going on?
You've been on the angel's trumpet.
Well, no. As it turns out, this isn't a ghost story. It's a side effect of Zolpidem. So a prescription-only sleeping tablet. For most people, Zolpidem works as intended. You take it, you drift into sleep. But for some, it unlocks something far stranger. People rise in the night fully unconscious and begin to live out an alternative life, cooking, shopping online, even driving cars. The next day, they remember nothing. So there are case reports of people waking to find half-written letters, mysterious text messages they don't recall sending, or strange scrawls on the wall. One woman regularly went to the supermarket in her sleep. Neighbours saw her walking down the aisles, but she had no memory of it at all. Doctors call it complex sleep behaviour, but for those affected, it must feel like you are possessed by your own prescription. So this Halloween, remember, sometimes the spookiest poltergeist might not be knocking on your door. It might just be sitting in your medicines cabinet.
You have been listening to a 3 Apothecaries production. Sound engineer Jimbo Slough, original music Jamie Brewster, artwork by David Baker and Jacob Howard.
Thanks for listening to the Oral Apothecary podcast. For maximum effect, instill weekly.
This episode of The Oral Apothecary is sponsored by jamiehayes.co.uk.